Hi guys, and welcome back to my channel. My name is Yasmin and I am a pediatric ER and trauma nurse for about 2 years now. I was previously a pediatric ICU nurse, but I'm now in the ER trauma room. So with that being said, let's just get right into this video. So we are going to talk about today the most common diagnoses that I see in a emergency room, a pediatric emergency room at that. I'm going to talk about 8 diagnoses. There's obviously a ton of things that kids come in with, but these are just the most common things that I see. So with that being said, let's just get right into it. So the first one that I'm going to talk about is appendicitis. I see this all of the time in the pediatric world. To tell you what an appendix is, it's just a little, kind of like a little finger shaped organ that is pretty much has no purpose in the body. So to remove it, it doesn't really cause any harm. Kids don't need it, so it's easy to be removed, but it is a finger shaped little organ that kind of attaches to the end of the colon. It's going to be on the right side, so that's why you typically get your right lower quadrant pain. But that is what the appendix is. There's a little picture, and so that is the appendix. And so appendicitis, the itis at the end, ding ding ding, it is inflammation. So inflammation of the appendix, and that is what your appendicitis is going to be. So kids typically are going to be greater than 2 years old that come in with appendicitis. So anyone less than 2, we're not really thinking appendicitis. And the common symptoms that kids come into the ER with is right lower quadrant pain. You'll always see parents come in saying, my kid's having right lower quadrant, it's on the side of the appendix, I'm thinking appendicitis. It's not always going to be right lower quadrant. Sometimes it starts around the belly button, so the periumbilical pain. Sometimes it starts on the left side and migrates to the right side, but for the most part I feel like I see my kids complain of pain around their belly button, and then a few hours later they're complaining of like now right lower quadrant pain. So I see both. It's not always dead center on the right lower quadrant. A lot of kids come in and not everyone's going to have all these symptoms, but these are the typical things that I see: nausea, vomiting, constipation, diarrhea, all the signs and symptoms that can be for a million different things, but those are typically the things that I come in with. Fever, I don't always see fever, especially if it's early on in the appendicitis progression, but if it's later on I do see fever. So kids will come in with belly pain, fever, ding ding ding, we're thinking appendicitis. So typically as a nurse, these kids come in, they're talking about belly pain. Any belly pain, automatically I'm going to say NPO, which is nothing by mouth, so nothing to eat or drink. I always advise parents that, just because if it is appendicitis, they're going to the OR, they need to be NPO for. So that's just going to prolong their care if they ate or drank anything within that time frame. So I always say NPO. Typically these kids are going to come in, they're going to get blood work. We're definitely looking at, most of the time we're looking at the CBC, which is the white blood cell count. If it's an infection process, you're going to see that white blood cell count go up. If it's high enough, it determines kind of the path that we take to determine if it's appendicitis, as in, will we do an ultrasound, will we go straight to an MRI, will we do a CAT scan, things like that. So that will determine just the path that we're going to take as providers for this patient. And with that blood work, we're probably going to give them a bolus of, if they're dehydrated, because a lot of times they have a loss of appetite, they're not eating and drinking at home, so they might be dehydrated. So we will give them a bolus and then just start them on maintenance fluids because they're NPO and can't eat or drink anything by their mouth, just to keep them hydrated throughout their stay in the ER. If the pain is severe enough, we will do some type of medication, whether that be, sometimes these kids come in right away, I might just give them some Tylenol or some Motrin just to start out. But if it's severe, we might do some IV morphine because they're going to have an IV placed. So might do some IV morphine just to kind of kick that out of the park. One thing that I will mention is that kids sometimes come in excruciating pain, like they cannot sit still, they're wincing, they're screaming, they're uncomfortable, they're in a 10 out of 10 pain, it's clearly visible, and then all of a sudden they're in like no pain and they feel so much better, which to us, to the parents, to the kids is like, great, there's no more pain. But that could mean that their appendix was just so inflamed, causing so much pain, and then it ruptured, causing excruciating pain, and now the pain is gone because the inflammation has just gone away. So that is not good, because now all of the pus and the bacteria and all that stuff is just floating around in their belly, which is definitely not a good sign. It increases your risk for sepsis, which is a really bad infection, and we do not want that. So we do want to be mindful of that. So yeah, that is typically your appendicitis. They will go to the OR at some point if it is confirmed appendicitis. It might be that day, it might be the next morning, but typically when they're admitted to the OR, we do start them on IV antibiotics. Most of the time that I have an appendicitis patient, they are normally getting Flagyl and Rocephin. So I normally give those while they're down in the ER before they go up to the OR, and we continue them on maintenance IV fluids and kind of manage their pain while they're down in the ER. So that is typically appendicitis in a nutshell. Very quick and simple things that we do as nurses, and kind of what to expect in kids when they show up with the abdominal pain and all the other symptoms. One of the diagnoses for number 2 that I see most commonly is asthma. And asthma exacerbation I see all of the time. Kids are always, can be triggered by seasonal, can be triggered by higher intensity and activity, could be triggered by change in weather. Kids have different triggers, but I always am going to see at least an asthma exacerbation in my 12-hour shift. Airway is going to basically get inflamed, and it's going to get narrow and swell, making it a lot more difficult to breathe. They're going to produce this extra mucus, which is why you see these asthmatics sometimes coughing a whole lot. So they might not be wheezing, but they might be coughing, which will basically warrant them some albuterol use. Even if they aren't wheezing, just the coughing alone and having the history of asthma will get them some type of albuterol use and steroid. Kids come in to the ER and they're complaining of trouble breathing, they're complaining of wheezing, they're complaining of trying albuterol at home and it not helping with their difficulty breathing, anything along those lines. When they have a history of asthma or a history of albuterol use, we are going to obviously initially get their vital signs, put them on a pulse ox, get their pulse ox, make sure they're satting and their saturations are where we want to see them. If their saturations are good, we do not have to think about supplemental oxygen as in a nasal cannula or things like that. But obviously if their saturations aren't maintaining, especially below 90, then we will put them maybe on 1 liter, 2 liters, something like that. But when these kids come in, as a nurse, I'm going to initially listen to them. If they're having expiratory wheezing, inspiratory wheezing, if they're retracting anywhere, having any signs of accessory muscle use for their breathing, if their saturations, like I said, are not where we want them, if they can barely get out a sentence or count to 10 without taking a couple deep breaths, things like that, we are going to formulate a score. So we have a respiratory score from 0 to 10, 10 obviously being the most severe and 0 being, or I think they all get 1. So 1 to 10, 1 being they look well appearing, they're not working a lot, they might be breathing a little tachypnic but otherwise look good, but 10 being the absolutely worst. They get a score. The score is going to determine what kind of treatments they get. We always ask if they have used a steroid at home, because most of the time these severe asthmatics are going to get a steroid, which normally is Decadron. It's an oral Decadron that they take by mouth, and then they'll get another dose in 24 hours when they're home, if they go home, or if they're admitted, they'll get it in 24 hours from the time that we give it in the ER. But most of these severe asthmatics will get a steroid. So when we score them, we get a score. They're going to be mild, moderate, or severe, and that determines what kind of treatments we get. Mild is going to get your inhaler with a spacer if they're young enough, and they'll get maybe 4 or 8 puffs depending on their weight. We'll do, sometimes these kids will get 1 treatment and then we'll try to assess them and see if they need more. Sometimes they get puffs every 15 minutes until they're okay enough to not need it, then we'll wait and assess. Our moderates are going to get nebulized treatments, so those are going to be 3 back-to-backs, we call them. Could be a duoneb with albuterol and Atrovent, but most of the time they're going to be 3 back-to-back treatments of albuterol and going to be the nebulizer. So we'll get those respiratory. We are blessed in our children's hospital to have a respiratory therapist, so they will do the treatments. But I do know, as a nurse, you should know how to set up a nebulizer. But they'll get those, and your severe Sometimes it's severe. We'll start with 3 back-to-backs. If there's no change in their status, then we will do a continuous albuterol nebulizer, which basically the mask stays in their face for an hour and we assess after an hour. Sometimes kids need it for multiple hours, which means they're probably going to get admitted into the hospital. So that is your asthma exacerbation in a nutshell. Wheezing is like the #1 sign and symptom of asthma. If they're super tight and you cannot hear good air exchange, you might not hear wheezing until you kind of open them up with your albuterol, and then you will hear wheezing. So if there's no wheezing and these kids don't look good, they're probably not moving a lot of air. So that means they need to get roomed immediately and they need to get some treatments. So sometimes even your very severe asthmatics, on top of the Decadron, they sometimes will get a mag rider, which is magnesium sulfate. Magnesium sulfate is a bronchodilator, so it's going to open up your bronchioles to make it a lot more easier to breathe. So if a steroid doesn't open up things enough for you to be getting adequate air exchange, then the mag sulfate rider as a bronchodilator will do that for the patient. We do monitor them, put them on a full monitor. We do monitor their blood pressure every 5 minutes because mag sulfate can make you hypotensive. I normally set up a bolus, at least in my room, put it on the IV pump just in case, and I monitor them because if their blood pressure does drop, then we want to be able to increase perfusion and get their blood pressure back to a normal range. Right, so #3 most common diagnoses I see in the ER is an extremity injury. So kids love to just, especially in the summertime, like the monkey bars is a common thing that kids always come in. They're always saying, we have a park at the hospital, so I feel like they're always saying, I was playing on the monkey bars and I fell, and they have some type of deformity to their wrist or forearm. But I always get extremities, whether it be in kids playing sports or just running down the stairs, around the house, playing on the trampoline, like anything. Kids are so active that we always are going to see extremity injuries. And lacerations. I'm just going to kind of group them together because I know they're 2 separate diagnoses, but lacerations and extremity injuries are like one of the most common things that I see. So for extremity injuries, when a kid's come in and they complain of right wrist pain, left ankle pain, something like that, we're obviously going to medicate. If they have not gotten Tylenol or Motrin, we want to do Motrin just because it's an NSAID and the inflammation, to help the inflammation. But sometimes we just do Tylenol, just depending on patient and parent caregiver preference and if they got something at home. So we always want to medicate one or the other when they come in, and then we will order x-rays. If it's an ankle, we'll order an ankle x-ray. If it's the wrist, we might order a wrist x-ray if they can pinpoint that it's the wrist only. If it's little kids that can't really say it's just my wrist, we'll do a full forearm x-ray, which includes the wrist, and so on and so on. So we order x-rays and we medicate these patients. For lacerations, we pretty much do the same thing. We will medicate with Tylenol or Motrin depending on preference and if they receive something prior to arrival to the ER. And then we will put on something called LET. LET is just what we say is a numbing gel, which we apply straight to the laceration. It stays on for about 30 minutes before a physician sees it, just so that it can numb the area pretty well. And then once it's pretty numb, the physician will come in, clean it out, and determine if they need sutures, if they need stitches. I mean, the stitches are sutures. Sutures, glue, steri strip, something like that. So those are just the things we get started, just so that it makes the process in the ER a lot easier, but definitely see them a lot. If the patient comes in with a deformity to the arm, so they have a fracture, they lift up their arm and there's a clear deformity in it, that is definitely going to be a sedation in the ER. Most of the time it's an ulna and radius, although I can't speak today. Ulna and radius fracture that has some type of deformity, it's displaced. We will consult orthopedics. We will put an IV in to prep for sedation in the ER, which typically we use ketamine as our sedation. The kids will get reduced, we call a reduction, so they'll get reduced. The orthopedics will come and kind of put everything in place in the ER, cast it up, and they will follow up outpatient in about a week and get follow up with orthopedics on an outpatient basis. For laceration, sometimes the location of it, if it's like above the eye for a little teeny baby, or like a 2-year-old, someone young. If it's a super deep, maybe extensive procedure to be able to suture it up, sometimes we will sedate them as well in the ER. But sometimes we'll just kind of local lidocaine to it and suture that up and just kind of hold and then give them a popsicle and a prize afterwards. So it all depends. It can go from a little bit of intervention to a lot of intervention. Just kind of depends on the severity of the fracture and or laceration. Now, if it's a laceration and a fracture, then that is called an open fracture, and that requires IV antibiotics. You're gonna go to the OR depending, or you might just do IV antibiotics, and our orthopedic surgeons will come down to the ER to repair that, and not our ER physicians. So it kind of just depends, but yeah, that is the gist of the extremity and lacerations. Right, so the 4th/5th, because I kind of did 2 last time, common diagnoses that I see in the ER is gastroenteritis. We see this all the time. These kids come in vomiting, diarrhea, the stomach bug is going to be our gastro kids. So gastroenteritis is basically just your intestinal stomach infection, stomach flu that you're gonna most of the time get from maybe a contaminated food or drink. Sometimes you'll just be contaminated with a person who has the stomach flu that gives you the stomach flu, and you just, the whole family has the stomach flu. So it can, but it is basically just the flu intestinal type of infection. The symptoms that kids are gonna come in with is vomiting. Obviously they're going to be vomiting, can't keep anything down. You'll always hear, my kid can't keep anything down, we try feeding, he's throwing up, even water, throwing up, like their stomach is just rejecting everything. So vomiting, you're going to have diarrhea. Sometimes kids have both, sometimes kids have one or the other. Cramping, abdominal cramps. I mean, you know us as adults, when we eat something bad, like you can feel the bloating and the cramping in your stomach and the bubbling, like people say. Sometimes kids are gonna have that too. They might not be able to express it as much, but they're definitely gonna have that. Sometimes these kids have fever on top of it, so it might look like, and I know we talked about appendicitis with the fever, abdominal pain, vomiting, diarrhea. It's like all the same symptoms. Kids might come in with these symptoms, but if everything else pans out and we're doing all these excess tests and everything's normal, then it's most likely a viral gastroenteritis, which sometimes we have to do all the things, ultrasound, maybe MRI, because they're having these symptoms of other things, but it just ends up being a gastro. So yeah, fever, vomiting, diarrhea, cramps, things like that, you're definitely going to see, are the tail signs that you're going to see in this diagnosis. If they are very well appearing and they vomited in the last few hours of coming to the ER, we will give them some Zofran. Normally it's the ODT Zofran, which is going to be under your tongue. It's going to dissolve. We wait about 15-ish minutes, and then we try to PO challenge them, which PO challenging is forcing them to drink fluids at a slow rate so that we can hydrate them that way. In the ER as a nurse, once I give the Zofran, I will teach them oral rehydration, which is basically, in simple terms, you're going to give the parents some form of liquid, whether it be apple juice, whether it be Pedialyte, whether it be Gatorade. You're going to give them that, and then you're going to give them a syringe. You're going to do a little bit at a time until they can tolerate. We don't want to just chug juices, because your stomach, with the virus that's going around in your stomach, it's just going to cause you to vomit again, and then it's just going to cause more issues, and we don't want that. So we want to just teach parents to just take it slow, is all I can say. So basically you give them a syringe, you give them their preference of drink, and you pull up 10 cc's of liquid. The patient drinks it, they wait 5 minutes, they do another 10 cc's, they wait 5 minutes, do another 10 cc's. They do that 4 times, and then they'll do 20 cc's every 5 minutes, basically, until they can tolerate. And that's kind of just a way that we can teach parents to just do it slow, instead of giving them a whole can of Gatorade and saying drink. So it's easy to keep track. As nurses, we can go in and keep track and things like that. If they vomit, we'll wait 20-30 minutes and then try again. If they keep vomiting or can't tolerate or don't get a certain amount of time within a certain time frame, then we're most likely just going to put it in an IV. We do want to try to avoid putting in an IV if they look well appearing and don't have a lot of signs of dehydration, then we want to try to avoid the IV. But sometimes it's inevitable. Kids just refuse and don't want to drink. Their stomach feels bad. They have a stomach ache. They don't want to drink. So we just end up putting an IV in, which is fine. We give an IV, we give a bolus, put them on maintenance fluids, and still encourage them to drink while they're getting all these fluids, but at least they're getting hydrated while they're attempting to PO. Sometimes these kids get admitted because they refuse to just PO, and they get observed for 24 hours and they get sent home. But that is the gist of the gastro. We'll check a sugar when they come in, especially if they vomited a bunch of times at home. We will check a sugar just to make sure that's normal, because a lot of times these kids come in and they look so good, but their sugar is like 40. And that means, yeah, we're putting an IV and giving a D10 bolus. So we definitely want to check a sugar when they first come in, just to make sure it's normal range before we start trialing the PO challenging. Guys, so I'm not sure what number I'm on, maybe 6, 7 common diagnoses in the ER. I've lost track at this point. But the next one I'm going to talk about is bronchiolitis, another respiratory diagnoses that I see a lot. Oh my goodness, especially during flu season. I see this all the time, especially in our little nuggets. Basically, bronchiolitis is an infection of the respiratory tract. It's going to affect the tiny airways, which are the bronchioles. Here's a little picture of them. Our younger kids are definitely going to, bronchiolitis is going to be the tiny airways are going to get infected by some type of virus. We have a skew of viruses that's going to affect it. We normally give these kids, we don't always, depending on severity of how these kids come in, but an RVP, which is a respiratory viral panel, will determine which one of these viruses is causing the bronchiolitis. RSV, I'll just say, is a more common one that we see in kids. Kids will come in and it's like a tell. We can see these kids. We're like, that's an RSV kid. Like, we can just see it, just the symptoms they have. But yeah, RSV, enterovirus, rhinovirus are just some of the viruses that will affect the airway, which will cause a bronchiolitis. So a lot of these kids come in and they have a ton of mucus and secretions, especially in their nose. They're super congested. Our little babies that come in with it, babies are airway breathers, so when they try to feed and breathe at the same time, it's very hard for them to do both simultaneously. So a lot of these kids will have a decrease in PO intake because they're so clogged up with mucus. So these kids that come in, the first thing that we want to do, especially as nurses, is obviously get vital signs, see how fast they're breathing. If they're breathing very tachypnic and breathing very fast, retracting, working, different types of retractions, subcostal, intercostal, supraclavicular, I can't speak today, then yes, we want to suction. Even the kids that come in that are barely working, that look so good, we still want to suction because it's definitely going to help clear that airway. So yes, we want to suction them and get all those boogies out, because a lot of times when their airway gets pretty cleared out with all the boogies, they stop breathing as fast, or they'll just take a bottle, because some of these kids just don't want to drink when they're so clogged up. I mean, you know what a stuffy nose feels like it's not fun. So yeah, we suction them, we get their vital signs, we get them on a pulse ox, a continuous pulse ox, just to monitor their saturations. In the mild cases, suction and PO trialing, they take down a bottle, they go home. We encourage suctioning at home, especially suctioning before bed and suctioning before feeds. In the moderate to severe, sometimes these kids just need to be on some type of oxygen. So we might put them on a nasal cannula, 1 or 2 liters to start. Some of these kids that are very severe, that are just working and breathing and so tachypnic, will by themselves just automatically to the Vapotherm. So we use Vapotherm, which is a high flow and not low flow like nasal cannula, just to kind of help with that work of breathing and get them to a more comfortable and less in a respiratory distress. And if they're on Vapotherm, they're going to get admitted into the hospital. If they are on nasal cannula and they're able to still PO and drink their bottles, then that's great. We encourage that, that's fine. But sometimes, well, most of the time, these kids that are on high flow and on Vapotherm and things like that will probably have an IV. So we'll put an IV in. We might just get some blood work just to have it as just a baseline and put them on maintenance fluids, give them a bolus if they're super dehydrated, not making wet diapers in a certain amount of time. A lot of these times, these bronchiolitics are gonna have abnormal breath sounds. They're not gonna be clear. They're gonna be super junky and coarse and crackly and things like that because there's so much junk in their chest and lungs. So you're definitely not gonna hear clear breath sounds most of the time, especially your RSV, rhino, entero, paraflu type of kiddos. You're not gonna hear that. You might even hear wheezing as well, which maybe they'll have to get some albuterol and then get on a Vapotherm, but you're definitely not going to hear clear is what I'm going to say. You're definitely going to get a chest x-ray on these kids most of the time because you want to see and visualize their lungs instead of just hearing. You want to be making sure that it's not like of pneumonia, because some of these kids look like it could be bronchiolitis, but then you get a film on them and it's a lower lobe pneumonia, and that means they need antibiotics. If it's bronchiolitis, it's viral, they won't need antibiotics, but pneumonia, bacterial pneumonia, you're definitely going to need antibiotics. So you want to visualize. So a lot of times these providers will order a chest x-ray on these kids. All right, so the next most common diagnosis that I see in the ER is Croup and Stridor. Sometimes kids come in with just croup. Sometimes they come in with Croup and Stridor. Croup and Stridor is definitely going to be the more severe of the two. Normally a crouper is going to come in, get a steroid, and then go home. A Croup and Stridor has the possibility of staying overnight in our hospital because if the Stridor obviously doesn't go away, that is not good. So croup is basically your airway swelling. A steroid is going to open that back up and make it a lot easier to move air. So the telltale of croup is going to be your barky cough. Some people call it the seal cough. I call it a barky cough. Once you hear it, you're never going to forget it because you can't have a barky cough and not know what that is. So if you hear the cough, it is a crouper. It's going to need a steroid. So here it is. That is your barky cough, guys. Sometimes in like our little babies, they might not have the croupy cough, barky cough, but they might have like a very raspy cry. Like it's very hoarse and you can hear it. Like some of these babies will just have this cry and you're like, that's croup. So it's basically going to be your croup is going to be your upper airway. So your larynx and your trachea is going to be swelling basically. When it's starting to swell, you're going to get that barky cough. When it swells enough, you're going to get that squeaky kind of sound, which we call stridor. So the more severe that croup gets is when stridor is going to develop. So that's why when you have stridor, you're going to need a little bit more than a steroid to kind of open things up and make the kid be able to breathe a little bit better. Symptoms, I kind of already talked about it. The stridor could be a sign or symptom, barky cough, the hoarse kind of cry, raspy kind of voice. You could have, it's a breathing, it's an airway kind of problem. So your obvious airway symptoms, retractions, nasal flaring, any type of things that's going to cause respiratory distress. Sometimes in the more severe cases, doctors will order a neck x-ray, which will kind of show the narrowing at the top, which people call the steeple sign, what doctors call the steeple sign. So sometimes you'll see that in the x-ray. Most of the time, I feel like when these kids come in with Croup and Stridor, these kids don't get x-rays. It kind of just depends how severe it is, but I feel like most of the time these croupers, I haven't seen an x-ray ordered, but it kind of just depends, like I said. But when it's just croup, you'll get a steroid, a PO steroid. It will be Decadron for the most part, is what I normally give, is Decadron. And then if you have Croup and Stridor, you'll get racemic epi, which is a nebulized treatment. You'll get that. After you get that, we'll assess every hour for up to 3 hours. If Stridor comes back within that time frame, then you'll get another racemic epi and then get admitted at that point. If you need it twice, then you're going to get admitted for observation, just because. And sometimes these kids obviously get IVs if they're dehydrated. It kind of just depends. So when these kids get racemic epi, I'm going to put them on a full monitor. It's just like epi, like you're going to have those signs and symptoms. You could have a regular heart rate. You could have an increase in heart rate, flushing, sweating, tremors, things like that, like the shivering. So we're going to put them on a monitor just to monitor their vital signs while they're getting the epi, obviously. But that is our typical Croup and Stridor that I see all the time, I feel like. So those are the most common diagnoses that I see that I will talk about Just other things off the top of my head that I can think of that I see a lot is our diabetics that come in, new onset and or known diabetes. I see all the time, which we have certain things that we do when they first come in, which I'll talk about in another video. We also see scrotal pain a lot, or males that come in with scrotal pain. We see sickle cell pain or fever is something that we want to hop on pretty quick, and things that we order and get things done. So I see that a lot. What other things do I see? I didn't talk about flu RSV, but I talked about it in the bronchiolitis, but definitely see flu RSV a lot. What else do I see? Foreign body swallowed. Like, kids love to swallow stuff, I swear. Like, even if it's in their nose, like they don't always swallow it, but they'll like put something up their nose or in their ear. I don't know what it is. Like, I think I had a kid, I don't even remember, but I was like, he was older too, and I was like, what made you want to do that? He's like, I don't know. I'm like, okay, well, that's cool. So definitely see a lot of foreign bodies in the ear, nose, and definitely swallowed. And just to kind of briefly talk about it, if it's a button battery or magnetic, that is very severe. So we want to get an image and kind of see where it's at very, very quickly, because that is high risk for bad things to happen. If it's something like a quarter or something and it's already in the stomach, we don't do anything about it. They're gonna poop it out. But depending on where it's at, it could be an airway emergency. They might go to the OR. But yeah, I definitely see kids swallow things a lot. So that is all the diagnoses that I see most common in our pediatric ER trauma room. If you see anything that I haven't mentioned or that you want me to kind of go more in depth about, I know the last couple of things I didn't really talk too much in depth about, but if you want to hear about them more, just leave a comment below. But if you like this video, give it a big thumbs up, leave a comment, and subscribe, and I will see you guys in my next video. Bye.